I supported the Ebola emergency response in West Africa at the peak of the crisis. After a few months on the ground, I realized Ebola gets too much attention. Ebola tested the world's ability to respond to a crisis, and we failed. We failed on several fronts. Over 11,000 people have died. Over 16,000 children are orphaned. Villages, communities, families wiped out, economies destroyed. Of course, we need new capabilities, better systems, better tools. We need to do more, be better, move faster. But there's something else we need. We need to think differently. Our current approach focuses on Ebola, the virus, the disease. I call it the virus-centric approach. We search for the virus in people, we isolate the virus-infected person, we try to treat the virus-affected patient, and if we fail, we look to bury that virus-ridden body. The virus-centric approach gets us to important answers. It helps us understand what the disease is, how to deal with an infected patient, but it misses something. The virus doesn't spread Ebola. People spread Ebola. And people are far more complex than viruses. People are part of families. They're part of communities. They're part of religious groups and ethnic groups. People want to take care of their sick. They want to embrace their dying. People spread Ebola. So if we want to stop the spread of this outbreak, we need to move from a virus-centric approach to a people-centric approach. Why change our strategy? Because despite our successes, we had numerous mistakes, fumbles, course corrections, and again, it was when we did not fully understand the people aspect. And every mistake is lost lives. The problem of burials is a great example of why we need a new strategy. The dead body is the most infectious point in the life cycle of an Ebola virus. In West Africa, there are traditions around washing and cleaning this body and embracing the dead during a ritual burial. So burials were becoming a major source of infection. We knew our response had no chance of success unless burials became safe. When I was supporting the operational planning in Liberia, I thought the burial strategy looked great. We had an excellent plan, great implementing partners, radio announcements, social mobilizers, even early success. All set. Or so we thought. Several communities resisted. You see, burials are based in deep-held beliefs that a traditional hands-on ritual is needed for the spirit to pass on peacefully. In many communities in West Africa, people save their entire lives to afford an appropriate burial. They sometimes spend more on it than a wedding. So people continue to bury bodies themselves, or they would wash and clean the bodies quickly before the burial team showed up. Or in some cases, the resistance wasn't even that secret. The burial teams were attacked as soon as they got near a village. It's not that people didn't understand. One man, after he and 7 others of his family got infected from burying his father, said, "Of course I know I might die, but how can I live if I don't bury my father properly?" Our strategy was based on scientific logic. People operate on emotion, traditions, beliefs. It became clear that our safe and dignified burial strategy was not going to be fully successful unless people were willing to partner with us. And we were learning. Where we took a people-centric approach, we had success. Where we had the trust of people, they let responders in. They called hotlines, told us where there was a death or someone was sick in the community. Where we were willing to listen, people gave us solutions. They said, "You know, if there was someone from our own community, one of our boys, who was part of this burial team, that would make us feel better and trust us more." They said, "If the body bags were white instead of black, that would respect our customs more." Where we observed, people showed us the way, like in Harmonfield in Liberia, which despite being surrounded by areas of high infection, remained Ebola-free. This is because the community leaders of Harmonfield created their own people-centric approach. They set up hand-washing stations. They created a self-monitoring program for the households. And so the question for the response then is, how do we build on these solutions? How do we add to what they've already developed? Partnership with the community is not always easy. In the crowded slums of West Point in Liberia, cases were increasing rapidly. The response was not able to turn around the long-held mistrust in government or quell the rumors that Ebola was some sort of foreign or government conspiracy to kill them. The quarantine center, which was a converted schoolhouse where cases from all over was being brought in, was run over by an angry mob. The military was brought out in full force. There were curfews and barricades and barbed wire. The resistance only became stronger. The shouts of "there is no Ebola" just got louder. No medical solution was going to be sufficient. But community leaders persisted. They brought survivors back in who could share their stories. The quarantine center, which had become the flashpoint in the riots after it was closed, the UN, international NGOs, and local NGOs partnered with the community to refurbish, renovate it back into a community school. This persistence with the community, this willingness to listen to them, to win their trust, is the reason why West Point is Ebola-free today. This people-centric, co-led model will have its critics, not because it doesn't make sense, but because none of our strategies and our institutions are set up for this. So I've heard pushback. One of them is, yeah, this all sounds great, but we need to move fast in a response. Yes, but can we actually move fast if we don't have the support of the people in the affected communities? In Guinea, where this crisis actually started over a year and a half ago, cases continue to fester because of community mistrust. In Liberia, which had the most cases at some point, they were able to turn this around and become Ebola-free for a good period of time, and it's universally acknowledged amongst those in the response that this is in large part due to the efforts of the community. The other pushback I hear is, you are highly overestimating the capacity of these poverty-ridden communities to come up with answers. True. They may not have all the answers, but neither do we, and when has that ever stopped us? This is a new way of thinking. Not just for this Ebola crisis or the next one, but for any crisis. Because we know the next time this could be much worse. The next virus could affect a much more populated city in Africa, in India, in China. The next virus could be airborne and spread faster. So, what does a people-centric model look like? The next time, we in the international community and the national response need to think, act, and respond differently. We need to go into communities not just to inform them, but to listen to them, to hear their questions, their concerns. We need to bring their community leaders into our planning meetings, understand what solutions, what resources they already have in place, and build on those. We have to reorganize. Our response protocols, our processes, our teams, our institutions. Community engagement is not just some parallel work stream. We need to bring this people-centric approach into our core strategy, one that is jointly developed by epidemiologists and anthropologists. We have to invest, not just in drugs and diagnostics and vaccines, all of which are critical, but still only address the virus-centric part of the problem. We need to invest in understanding traditions and beliefs, in mapping local networks, identifying influencers, figuring out community structures that can be quickly activated in the next crisis. The next time, we cannot wait for a mistake. We need to go to the people and the communities first, to create solutions not just for them, but with them. Thank you.